We also do system performance measurement in Canada, both across Canada and within individual provinces. And our dream is that all we have to do is to show the data and change will happen. The problem is that usually doesn't happen, but sometimes it does. And so this particular example from a few years ago, we put out a report. It's kind of washed out there, I think, but it's what the measure is the proportion of mastectomies that are done as day surgery. And what you'll see is that the Alberta, which is the second province from the left there, was an outlier at 1.4%. And so when we did this report for the first time, the CEO of the Cancer Agency in Alberta, I think this particular issue had just never been on the radar screen. And so with absolutely no effort on our part, she basically went back and told her hospitals, figure out how to do this. And so that was 2015. 2016, it went from 1.4%, 6.3%, 34%, and in the first 6 months of 2018, 40%. So a huge change in this case, just from showing the data. So sometimes it does happen. I'm glad that Rue introduced the issue of single fraction palliative radiation for bone metastases, because that actually is something that we have done a demonstration project around. So you may be familiar with the Choosing Wisely campaign. There's also, we have a related Choosing Wisely Canada one, and one of the measures was, or one of the recommendations, do not recommend more than a single fraction of radiotherapy. And when we looked across the country, we saw that there were outlying practices, and in particular, these two provinces that are side by side in the prairies, Saskatchewan and Manitoba, had the highest rates at just about 70% of patients receiving multifraction radiotherapy for bone metastases. And as Rue mentioned, there's actually great evidence that this is unnecessary. Randomized trials, systematic reviews of randomized trials, guideline recommendations from professional groups, et cetera. And the thing is, this has several impacts on the cancer system. So across Canada every year, 11,000 patients receive multiple fractions of radiation to the bone. And so if we were able to reduce this by 15%, that's 1,500 patients who don't have to come back day after day after day for multifraction radiotherapy, because sometimes it's 2, sometimes it's 5, 10, 15. I've seen as much when I was in the United States as 30 fractions for bone metastases. 15% reduction would save 2,000 hours of linear accelerator capacity and would save $1 million that could be redirected to other parts of the healthcare system. So we wanted to do something proactive to try to address this, and these two provinces were also interested in this. So we developed a plan for change. First of all, measurement, showing people the evidence, showing people their own data, engaging stakeholders to identify what are the barriers to the care that we're interested in, and then developing with them, as opposed to in a top-down way, what the strategy should be. And then implementing that strategy, first on a small scale, but then evaluating it, and if it's successful, to scale up and spread to other jurisdictions. So this is an example of the type of data we were able to go to a local institution with. So each line here is a different radiation oncologist who's treated bone metastases, and this is over time, 2013 to 2017. And what you can see is that they're all over the map in terms of the proportion. This would be the proportion of multifraction radiotherapy. So you see there's one, and maybe in the later years a couple that are down in the range where we think this should be, probably in the 25 to 30% range. The reason being is that if the bone metastases are considered complicated, then multifraction treatment is appropriate. But you see several that are always at very high levels. So we started off by engaging the stakeholders to identify the barriers to this. And the types of things that we came across is, first of all, organizational practice culture, social influence. You know, radiation oncologist was trained years ago, trained to give multifraction radiotherapy. Many of their colleagues do. It's just the culture. Knowledge gap is another thing. Not everyone was aware of the data and evidence and recommendations around this. Also about the definition of what an uncomplicated bone metastasis is. So complicated is essentially if it's associated with a pathologic fracture or spinal cord compression, but what if it's an impending fracture, and how impending does it have to be? How much of the bone cortex, et cetera? It turns out that when we brought these people together, they realized that they all had very different definitions of what constituted a complicated or uncomplicated bone metastasis. And then just personal beliefs. So while there's strong evidence that the outcomes are equivalent overall, there is patients who receive a single fraction do have a risk, a minority risk, of needing to have another fraction at some point in the future. And so that leads to some medical practitioners who maybe don't think at a system level or don't want to think at a system level say, well, you know, I can reduce the risk of them needing to come back for another fraction by treating everyone with multifraction radiotherapy. So you do come across these sorts of personal belief issues as well. So we met with the stakeholders to brainstorm what sort of things might be able to work here. And so some of the principles that came out was that radiation oncologists, at least in these jurisdictions, are receptive to perceived experts. Getting the support of local medical leaders and champions was important. Again, the idea of incepting the change as opposed to dictating the change, having it come from this group, and revisiting the issue multiple times in order to reinforce the change. And then planning to measure the outcomes and assess the uptake of change. And so with this, we developed a multi-pronged intervention strategy, which involved these different things, which I'll now go through one at a time. So first of all, the idea of roadshows, and this was mainly grand rounds. So we got 2 respected Canadian experts in palliative radiotherapy to come to each of the institutions in these provinces. They came and spoke about the evidence. Dr. Dennis from Ottawa, Dr. Olson from British Columbia, where the rates of multifraction was quite low, talked about why that was in British Columbia, how it had happened, et cetera, to give that example. And then to really put in a lot of effort to make these seem like important events. So had invitations coming directly from the chief medical officer, posters, reminders, inviting the whole team, radiation therapists, physicists as well, so not just the oncologists, and probably most important, providing lunch. And then followed these up by having consensus meetings with the local practitioners at their institutions, again, providing food, personal invitations, and having a discussion about the evidence, about the recommendations, and reviewing the local performance data. And this is where you started to see people realize on their own that their practice was different from their peers, considering these sorts of things. And then did a survey to measure their intentions and attitudes towards the recommendations, to remind them about the different issues, try to gauge the enthusiasm, how successful was this likely to be, and the effectiveness of the whole roadshow type of idea. And then here's where all of that was leading up to probably one of the most important things, which was to get each of these groups within their institutions to agree to actually changing the way their order entry process worked. So in all of these institutions, the prescriptions are electronic, and what we were able to get them to agree to was to have the default when they went to write an order, be a single 8 gray fraction of radiation. They could pull down a menu and override it and do something different, but make it easy to do the right thing. Sorry. And then, of course, the last phase of this is evaluation with audit and feedback. Unfortunately, that's not going to happen until 2019 because this is still a fairly new thing. However, all the anecdotal feedback from both of these jurisdictions is that there has been already a very significant change in practice, and I think it would be very surprising if we don't see major changes in the rates when we measure this again. So why was this effective in driving change? So first of all, I think single fraction radiotherapy, this is like the perfect thing. It's easily measured, it's easily understood, it's got solid evidence behind it. It's a multi-purpose indicator that speaks to several different aspects. There's the patient experience aspect, there's the sustainability of the system part of it. It's clear that it's considered evidence-based best practice. You're able to do essentially apples to apples comparisons. You know, people always say, well, my patients are different, I have more complicated patients. But when you actually look at it, it's more to do with how they considered those cases. The cases, as far as we can tell, are actually quite comparable that each radiation oncologist was treating. I think it was great that we had 2 adjacent provinces with very similar baseline results interested in improvement, because nothing would be worse in Manitoba than for Saskatchewan to have improved more and vice versa. And then also that there was great buy-in from leadership. They saw that they were the worst performers in the country and wanted to do something about it. So in conclusion, you know, just producing data is occasionally effective, but improvement usually involves a multi-pronged, co-developed strategy if you really want to make change in most cases. And with that, I'll end. Thank you very much.